Welcome to this comprehensive clinical training module on domestic violence. As registered nurses, you are often the first line of defense and the primary point of contact for individuals experiencing violence in the home or within intimate relationships. Your ability to recognize subtle indicators, perform structured assessments, and provide empathetic, non-judgmental care can literally be life-saving. Throughout this course, we will move beyond the surface level of physical injury to explore the complex dynamics of power, the barriers to seeking help, and the specialized nursing interventions required to support this vulnerable population. By the end of this course, the registered nurse will be able to define domestic violence and intimate partner violence, differentiating between various forms of abuse such as physical, sexual, psychological, and stalking behaviors. We will identify the types and patterns of abuse, including the escalation process and the specific phases of the cycle of violence. You will learn to recognize perpetrator characteristics, risk factors, and warning signs, while also describing the diverse populations affected, including women, men, children, and the LGBTQ+ community. Furthermore, we will explain the economic, institutional, and social barriers that prevent victims from leaving. Our clinical focus will include assessing the physical and psychological impact of violence and applying assessment strategies using validated tools. We will describe the essential role of healthcare professionals and identify the barriers to effective screening within our clinical environments. Finally, you will demonstrate appropriate nursing interventions, ranging from communication and documentation to safety planning, and apply a structured approach to management and treatment through the analysis of case-based scenarios. To begin, we must clarify our terminology. Domestic violence is a broad umbrella term used to describe abusive behaviors occurring among family members or within a domestic setting. It encompasses a wide range of harmful actions used to create fear and maintain control. This is not limited to physical harm. It includes emotional abuse, economic control, sexual coercion, and isolation. However, in recent years, the clinical community has shifted toward the more specific term, intimate partner violence, or IPV. While domestic violence covers various family dynamics, IPV focuses specifically on harm occurring between current or former partners. This distinction is critical because IPV applies regardless of the specific type of relationship or whether the partners still reside together. It is important for us to understand that patients may not identify with the term domestic violence if they are no longer living with the abuser, yet they may deeply relate to the concept of relationship-based harm. In the clinical setting, using the right language helps bridge the gap between a patient's experience and the help they need. The World Health Organization defines intimate partner violence as any behavior within an intimate relationship that causes physical, psychological, or sexual harm. This definition is vital because it emphasizes the behavioral nature of abuse and its broad applicability across all relationship types. It moves the focus away from a single event and toward a pattern of behavior. The Centers for Disease Control and Prevention expands on this by identifying 4 specific categories: physical violence, sexual violence, stalking, and psychological aggression. These categories serve as a reminder that abuse is not always marked by a visible bruise. Patterns of behavior that strip a person of their autonomy or emotional safety are just as damaging to their overall well-being as physical assault. Domestic violence is a significant public health issue that frequently presents in healthcare settings. Many individuals experiencing abuse seek medical care repeatedly, but may only present with vague symptoms or chronic complaints rather than a direct disclosure of violence. As nurses, we are in a unique position to identify signs that others might miss. We are trained to recognize inconsistencies between a patient's reported history and their observed injuries. However, the reality is that abuse is frequently underidentified. Patients often wait for us to ask the question. They may not voluntarily disclose their experiences unless we provide a safe, supportive, and non-judgmental environment. Because abuse affects everything from mental health and chronic pain to reproductive outcomes and pregnancy safety, Our understanding of this topic is essential for providing comprehensive, holistic care. For the registered nurse, recognizing domestic violence is a core competency. Patients often present with nonspecific symptoms, and early identification is our best tool for preventing further escalation of harm. Since nurses are often the first point of contact, whether in the ER, a primary care clinic, or home health, our initial response can fundamentally influence a patient's safety and their long-term health outcomes. Physical violence involves the use of force to harm or attempt to harm a partner. This can range from hitting, slapping, and punching to life-threatening behaviors like choking, strangulation, or the use of weapons. It is important to note that physical violence often follows a trajectory. It may begin with minor incidents that the victim or even the clinician might overlook, but it frequently progresses over time into more frequent and dangerous assaults. Sexual violence is any sexual act or behavior occurring without consent. We must remember that consent must be freely given and informed. The absence of physical resistance does not imply consent. This form of abuse includes forced or compelled sexual activity through coercion, acts committed when a partner lacks the capacity to consent due to impairment or fear, and abusive or degrading sexual acts intended to humiliate. Sexual violence often co-occurs with physical violence, creating a high-risk environment for the victim. Psychological aggression uses communication to harm a person mentally or emotionally. This includes verbal abuse, insults, and constant humiliation. Abusers often use isolation, cutting the victim off from family and friends, to maintain total dominance. While these behaviors do not leave physical scars, the impact on a person's autonomy and mental health is profound. Emotional and economic abuse are tactics used to maintain dependency. Emotional abuse focuses on undermining a victim's self-worth through constant criticism and manipulation. Economic abuse, however, is a more tangible form of control where the abuser restricts access to money, prevents employment, or monitors every cent spent. These forms of abuse make it functionally impossible for many victims to leave, as they lack the financial means or the self-confidence to survive independently. Stalking is defined by repeated, unwanted attention that causes fear. This includes constant messaging, following the victim, or showing up unexpectedly at their workplace. Stalking often continues and sometimes intensifies after a relationship has ended, creating a persistent state of hypervigilance and fear for the victim. It is critical to recognize that IPV is rarely a single, isolated event. It is an escalating process. What starts as name-calling or property damage can quickly progress to pushing and restraining, and eventually to severe violence like strangulation. Early intervention is the only way to break this trajectory before it reaches a fatal conclusion. By understanding these diverse forms of abuse, nurses can recognize non-physical indicators and identify patterns that are not immediately obvious. This knowledge allows us to ask targeted questions and provide informed support based on the specific risks the patient faces. At the very heart of domestic violence is the concept of power and control. Abusive behavior is not random. It is a deliberate method used to dominate and maintain authority. Abusers use emotional manipulation, intimidation, and the restriction of resources to create a state of dependency. Over time, a victim may walk on eggshells, adapting their every move to avoid conflict. This pattern persists because it is effective. It allows the abuser to maintain dominance without immediate consequences. As we discussed, the escalation of abuse is a hallmark of IPV. It rarely begins with a trip to the emergency room. It starts with the destruction of personal property or verbal insults. As the abuser tests boundaries, the behavior becomes more aggressive, eventually leading to severe physical assaults or the use of weapons. Recognizing this progression is vital for nurses to assess the urgency of a patient's situation. Domestic violence often follows a repeating cycle consisting of 3 distinct phases. The first is the tension-building phase. Here, tension gradually increases, and the abuser becomes irritable. The victim often tries to keep the peace by being overly accommodating, hoping to prevent an explosion. Next is the battering incident, which is the acute episode of abuse where the abuser exerts dominance through harm. Finally, we see the honeymoon phase. During this period, the abuser is often apologetic and promises change. The victim, feeling hopeful, may believe the abuse has finally ended. However, this calm is temporary, and the cycle inevitably resets to the tension-building phase. Understanding this cycle is essential for nursing because patients may present during any phase. A victim in the honeymoon phase may appear calm or even protective of the abuser, which can be confusing for clinicians. Recognizing these patterns prevents us from misinterpreting a patient's behavior and helps us provide support regardless of where they are in the cycle. While there is no single profile for an abuser, we often see patterns of emotional immaturity, strong feelings of inadequacy, and low self-esteem. To compensate for these internal feelings, the perpetrator uses bullying and intimidation to feel powerful. In many cases, these are learned behaviors modeled after dominant figures in the abuser's own past. For the perpetrator, violence is a tool. It is used intentionally because it works. It achieves the desired outcome of dominance. This is often coupled with distorted beliefs about relationship roles and a dehumanization of the partner. When there are no consequences for these actions, the behavior is reinforced and continues. While statistics show a high prevalence of male perpetrators and female victims, we must remain objective. Women can also be perpetrators, and abuse occurs in all relationship types. Female-initiated violence may have different tactics or intentions, and we must avoid assumptions to ensure all cases are addressed appropriately. Understanding these traits helps nurses interpret relationship dynamics more accurately. It reinforces the need for a non-judgmental approach focused on safety rather than assigning blame, while staying aware that perpetrators themselves may also be present in the healthcare setting. The World Health Organization identifies several risk factors that increase the likelihood of IPV. These include a family history of violence, substance use, low self-esteem, and personality disorders such as antisocial or borderline traits. Environmental factors like poverty and ongoing marital discord also play a significant role. These factors interact in complex ways to create high-risk environments. Triggers are specific events that precipitate an abusive episode. These are almost always rooted in control, such as a partner disobeying, arguing back, or not meeting household expectations. Financial questions or suspicions of infidelity are also frequent triggers. It is important to note that these do not justify the abuse. They merely highlight the abuser's sense of entitlement and control. Nurses should look for early warning signs like extreme jealousy, unpredictable volatility, and a history of resolving conflicts with violence. Cruelty to animals or an insistence that their way is the only way are significant red flags. By staying attentive to these patterns, we can contribute to early intervention efforts. Awareness of these triggers and factors enables us to ask more focused questions during our assessments and identify individuals at high risk even before an acute injury occurs. Victims of domestic violence transcend all demographics. They include women, men, children, and members of the LGBTQ+ community. While women represent a large proportion, men face unique stigmas when seeking help, and children are deeply affected even if they are only witnesses to the violence. An inclusive approach ensures no one is left without support. A common and damaging myth is that victims stay because they want the abuse. In reality, no one chooses to be harmed. The decision to stay is a complex survival calculation influenced by fear and a lack of options. We must replace victim-blaming attitudes with compassionate, non-judgmental care. Leaving is rarely as simple as walking out the door. Economic barriers, such as a lack of independent bank accounts or employment, create a state of entrapment. Institutional barriers occur when the legal system or community leaders prioritize keeping the family together over individual safety. Finally, cultural and social barriers, including the belief that divorce is unacceptable or isolation from support systems, create a profound sense of obligation and guilt. By understanding these barriers, nurses can avoid a judgmental tone. We must recognize that leaving is a process, not an event, and our role is to support the patient's autonomy throughout that difficult journey. Male victims often suffer in silence due to societal expectations of masculinity. They may fear they won't be believed or that they should have been able to defend themselves. Nurses must be sensitive to these unique challenges to encourage disclosure. In the LGBTQ+ community, abusers may use outing as a threat to maintain control. These individuals often face a lack of inclusive resources and may fear discrimination from law enforcement, making the healthcare setting a vital safe harbor. Children who witness violence are not bystanders. They are victims. Exposure is strongly linked to child neglect, behavioral problems, and long-term psychological issues. The impact of witnessing abuse is clinically comparable to being a direct victim of physical abuse. Exposure disrupts emotional regulation and social development, leading to a lifetime of vulnerability to mental health conditions. Understanding this broader impact is critical for family-centered nursing care. Nurses must provide inclusive, non-assumptive care, recognizing that signs of abuse present differently across these diverse populations. The physical toll includes fractures, chronic headaches, and gastrointestinal disorders. During pregnancy, the risks are even higher, including preterm birth and miscarriage. Victims often delay seeking care, which only worsens these outcomes. The psychological scars include anxiety, depression, and PTSD. Many victims present in mental health settings with chronic pain or stress-related disorders that are direct results of their history of abuse. Domestic violence strains our healthcare and social service systems and creates cycles of violence that pass from one generation to the next. Early intervention is the only way to break this chain. Nurses must recognize both physical and non-physical presentations to provide truly comprehensive care that addresses the whole person. Key indicators include injuries that don't match the explanation, repeated visits for vague complaints, and signs of extreme anxiety. We must remain alert to any inconsistency between what the patient tells us and what we see during our exam. The Spousal Abuse Risk Assessment, or SARA, is a validated tool that evaluates 20 indicators, including a history of violence and the use of weapons. This structured approach helps us identify risk more accurately. Beyond tools, we must use our eyes. Observe how the patient interacts with their partner. Are they fearful? Do they look to the partner before answering? In pediatric cases, observe for signs of avoidance or fear toward a caregiver. Nurses are the central figures in initial evaluation. Combining clinical judgment with validated tools like SARA ensures we don't miss those who are afraid to speak up. The Joint Commission requires healthcare organizations to have clear criteria for identifying victims of abuse based on observable evidence. Staff must be trained to apply these criteria to ensure no one falls through the cracks. Institutions are responsible for training staff, maintaining referral systems for shelters and counseling, and providing a safe, private environment for assessments. Nurses are the ones who put these policies into practice every day. By understanding these frameworks, nurses ensure they are acting in accordance with the highest professional standards, providing consistent and legal support to their patients. Early detection allows us to intervene before violence becomes fatal. Since victims often seek care for unrelated symptoms, we must be proactive. Patients are waiting for a supportive professional to ask them if they are safe. Opportunities are missed when we treat symptoms in isolation or fail to ask direct questions. We cannot assume that a patient will tell us if we don't ask. We have an ethical duty to maintain confidentiality and respect patient autonomy. Not every patient is ready to leave, and we must provide support and resources without coercion, ensuring we don't inadvertently increase their risk. Nurses bridge the gap between a patient's silent suffering and the help they need. Our role in initiating these conversations is vital. Lack of time, insufficient training, and emotional discomfort are real barriers for nurses. We must acknowledge these challenges to overcome them and prioritize patient safety in our busy schedules. Fear of retaliation and cultural differences can make patients uncooperative. We must adapt our approach to meet them where they are. A lack of standardized processes can limit our effectiveness. Advocacy for better resources and training is a key part of our professional role. Understanding these barriers allows us to refine our approach and ensure that screening becomes a consistent part of our nursing practice. Victims frequently present with anxiety, depression, or suicide attempts. Chronic pain with no clear medical cause, like persistent headaches or stomach disorders, should also raise our suspicion. Pregnancy is a high-risk time for the onset or escalation of violence. It is linked to preterm birth, low birth weight, and poor prenatal care. Routine screening during prenatal visits is absolutely essential. By recognizing these high-risk contexts, we improve the likelihood of identifying victims who do not have obvious physical injuries. Screening must be intentional and private. If a partner refuses to leave the room, you must find a way to separate them for a confidential conversation. Questions should be direct, normalized, and asked in a routine manner to reduce stigma. Use a non-judgmental tone and demonstrate empathy. When documenting, use the patient's own words in direct quotations. Describe injuries with clinical precision, noting size, location, and type to provide a factual record that supports future safety and legal actions. Determine if the patient is in immediate danger. Are there threats of homicide? Are there weapons in the home? Once assessed, provide clear information on shelters and support services, but always respect the patient's autonomy to make their own choices. Our role is to empower the patient. We provide the tools, the information, and the safe space, but the decisions belong to them. Managing domestic violence follows a structured path: identification through screening, encouraging disclosure in a private space, non-judgmental listening, and validation to let the patient know it is not their fault. We then proceed with documentation, a thorough risk assessment, and finally, referral and follow-up. This structured approach ensures that we address both the immediate safety of the patient and their long-term well-being. Following this structure allows for consistent, high-quality care that prioritizes the patient's dignity and safety. To conclude, remember that domestic violence is about power and control, not isolated anger. It escalates over time and follows a predictable cycle. Victims come from every walk of life and face immense barriers to leaving. As registered nurses, your role in early identification, empathetic communication, and structured assessment is the key to breaking the cycle and saving lives. Always respect patient autonomy, document with precision, and provide the resources necessary for a safer future.